Welcome to this OncLive News Network presentation broadcasting live from MGH Studios. Today's discussion will be focused on practical application of recent clinical data for immunotherapy in non-small cell lung cancer. I'm your host, Dr. Leora Horn, Ingram Associate Professor of Cancer Research and Clinical Director of the Thoracic Oncology Program at Vanderbilt University Medical Center in Nashville, Tennessee. Today I'm joined by two colleagues who are also experts in lung cancer research. Dr. Eddie Guerin, Associate Professor of Hematology Oncology at the UCLA David Geffen School of Medicine in Los Angeles, California, and Dr. Tom Stinchcomb, Professor of Medicine at the Duke Cancer Institute in Durham, North Carolina. During the next 60 minutes, we're going to navigate through some of the questions surrounding how we treat patients with non-small cell lung cancer. We'll consider how we are currently using immuno-oncology agents, how they are sequenced with other therapies, and how the latest data will help us in making these decisions in our clinics. During the last few minutes of this broadcast, we will answer questions that have been submitted through our broadcast by members of our viewing audience. Our first segment will focus on newly diagnosed non-small cell lung cancer. We're going to discuss patients who have recently been diagnosed with metastatic disease. The first trial to consider is KEYNOTE-042, a phase 3 trial comparing single-agent pembrolizumab to platinum-based chemotherapy in patients with advanced non-small cell lung cancer with a PD-1 score of greater or equal than 1%. Eddie, how has this trial influenced how you're treating your patients?
So to date, it's easy because the regimen has not been approved in patients with the 1 to 49% PD-1 expression, which is the group that is added to this from the KEYNOTE-024 study, which did show a clear benefit in patients who have this high level of staining for PD-1. That being said, this study is not something that I find to be very easily applicable to my patient population. It was conducted largely in places where the ability to receive a PD-1 or PD-L1 inhibitor after progression is quite limited. And in fact, only about 20% of patients did cross over to receive a PD-1 or PD-L1 inhibitor. In addition, although there was a survival benefit, it was clearly driven mostly by patients who did have high-level staining for PD-L1, the group of patients for whom pembrolizumab is already approved as monotherapy. For the other patients that were part of the study, those with staining for PD-L1 between 1 and 49%, there was a hazard ratio of 0.92, so there numerically it looked a little bit better for survival, but not tremendously better, and certainly wouldn't, in my estimation, look as good as the data that we have seen for chemo-immuno combos in that patient population. So for me, the only group of patients I see this being of potential utility is that I think at academic centers where we all practice, we tend to get a group of people who are looking to be aggressive in their care. In the real world, there are many patients who forego all treatment, and there is the potential that this would take patients who might otherwise choose to forego treatment and have them be willing to undergo single-agent PD-1 inhibition for the potential of a therapeutic response.
Tom, are you doing anything different? Do you have patients who maybe come in with a PD-L1 score of 30% and absolutely refuse chemotherapy? So do you think this is something that could persuade them to consider some sort of therapy for their disease?
I think there are a few patients, but we tend to select for the patients who want to be aggressive. We also have some patients who are maybe 85, 90, and a PD-L score less than 50%. These are the mutation-negative patients. I think you might be, if this is approved, be able to offer that elderly patient an option who may have concerns about toxicity with the chemo-immunotherapy combinations. But I think it's only a subset of our patients who are going to really be influenced by this trial.